Hi friends, today we are going to discuss another set of random one-liners in pediatrics. To start with, Holliday Segar formula is used to calculate what? We all know it is used to calculate calorie, but thing is that it can also be used to calculate both calorie and fluid requirement. So there is some differences are there that we have to know in this discussion. For calculation of a calorie, that RDA, it is expressed as the expected weight for that age of the child, not for the present weight. Suppose the age of the child is 5 years, weight is 10 kg, then calorie is to be calculated as per the expected weight for that age for 5 years, not the present weight, that is for 10 kg. That is the difference. So expected weight for that age is used for calculation of a calorie as per your Holliday Segar formula. But for fluid calculation, the present weight is used. This is the difference. For fluid calculation, suppose 5-year-old child having 10 kg weight, then fluid is to be calculated for 10 kg only, not for the expected weight. But for calorie requirement, for RDA requirement, we have to calculate as per the expected weight of the child. Up to 10 kg, it is 100 kilocalorie per kg, then 10 to 20 kg. For every 1 kg more, we have to add 50 kilocalorie per kg. Suppose up to 8 kg child, then the calorie requirement is 800 kilocalorie. After 10 kg, for every 1 kg increase in weight, we have to the calorie requirement will be 50 kilocalorie extra. Suppose 12 kg weight, then 1000 kilocalorie plus 50 into 2, that is another 1100 kilocalorie. 20 to 30 kg, the requirement is 20 kg child, so the calorie requirement is 1500 plus 20 kilocalorie per each kg. Accordingly, we have to calculate. So first 10 kg, 100 kilocalorie per kg, second 10 kg, 50 kilocalorie to be added extra, and 20 to 30 kg, 20 kilocalorie to be added extra per kg. This is the calculation. Fluid requirement as per the present weight, but calorie requirement as per the expected weight. This is the difference that we have to know. Next, which component of breast milk is responsible for breast milk jaundice? As you know, there are two terminologies. One is breast milk jaundice, another is breast feeding jaundice. The breast milk jaundice is because of the presence of pregnenolone and free fatty acid in the breast milk itself. Then what is the difference? Breast milk jaundice versus breastfeeding jaundice. Breast milk jaundice is because of the presence of the inhibitors in the milk itself. The inhibitors are pregnenolone and free fatty acid. But breastfeeding jaundice is because of the feeding inadequacy. Because of the feeding inadequacy, that lead to stasis, that lead to increased enterohepatic circulation, and that is the cause of the jaundice. So breast milk jaundice, its presentation will be little bit later, but breastfeeding jaundice, its presentation will be little bit earlier. Early in neonatal period, within the day 10 itself, the baby can present with breastfeeding jaundice. Treatment for breast milk jaundice is stoppage of feeding breast milk. But treatment of breastfeeding jaundice is frequent feeding. As you know, stasis, that is the cause of jaundice. So you have to frequently feed the baby in order to avoid this situation. Third, this is a case scenario. 8-year-old girl presented with features suggestive of pancytopenia with physical findings shown in the picture. Features of pancytopenia like your anemia, your thrombocytopenia, and leukopenia like. So infection will be there, bleeding will be there with severely pale child, and features what we are getting in the picture. There are some thumb abnormality, some radial bone abnormality, and multiple capillate spots all over the body. Then what is the diagnosis? As you know, this is one of the important question, and the answer is Fanconi anemia. This is what are the findings? What we will get in Fanconi anemia? There will be faulty DNA repair and increased chromosomal fragility to diperoxybutane. Clinical feature wise, we will get microcephaly, short stature, absence radius and thumbs, clinodactyly. We will get hyperpigmentation and extensive capillary spots and almond-shaped eyes. They are things that we'll get in Fanconi anemia. There we may get confused with your TAR syndrome. TAR syndrome is thrombocytopenia with absent radi. In both the cases, in your Fanconi anemia and TAR syndrome, in both the cases, radius will be absent. But how to differentiate clinically? In Fanconi, thumb abnormality will be there, thumb will be absent, but in TAR syndrome, thumb will be normal. So likewise, we have to differentiate, and we have to know this is one of the bone marrow failure syndrome, Fanconi anemia, microcephaly, short stature, absent radius, thumb abnormality, extensive capillary spots, and hyperpigmentation with features of pancytopenia. One thing we should come to our mind is Fanconi anemia. Next, Austin Flint murmur is found in which case? Answer is aortic regurgitation of severe variety. What happens in severe aortic regurgitation? Because of the regurgitant blood flow that will press the mitral leaflets, anterior mitral leaflets, and it behave like a functional mitral stenosis, and that is the cause of this mid-diastolic murmur. And the mid-diastolic murmur, because of the compression of the blood flow, the compression of the mitral leaflets by the jet of blood, is called Austin Flint murmur. Then to add, what are the peripheral signs that we are usually getting in aortic regurgitation in exam? Everybody is fond of asking all these questions. The signs we have to remember, these are demoset sign, Landau-Kleffner sign, Becker sign, many are there. What is demoset sign? This is forward or backward movement of the head, that is with your demoset sign. Landau-Kleffner sign, this is the contraction and dilatation of the pupil, that is Landau-Kleffner sign. Becker sign, it is retinal vessels pulsation is your Becker sign. Next, Quincke sign, this is the capillary pulsation in leaf and fingers. Muller sign, it's the fluttering of a uvula. Corrigan sign, it is also known as dancing carotid. Heel sign, this is the difference in upper limb and lower limb pressure, that is called your heel sign. Trough sign, this is the pistol shot sound which you are getting by compressing the femoral vessel, that is your trough sign. Rosenbach sign, pulsation of the liver, that is Rosenbach, and Gerard sign, this is the pulsation of the spleen. These are the signs we have to remember. That is your demoset sign, Landau-Kleffner sign, Becker sign, your Quincke sign, Muller sign, Corrigan sign, heel sign, trough sign, Rosenbach, and Gerard sign. Next, sudden onset of aphasia is noted in which seizure syndrome? Suppose one baby with a seizure, continuous seizure, and developed aphasia, then which disease we may suspect? Which syndrome we may suspect? Answer is LK syndrome or Landau-Kleffner syndrome. What are the characteristics? It is characterized by loss of a language skill and verbal auditory agnosia in a previously normal child. That we have to remember. Previously normal child with achieved milestones, with achieved language milestones, now developed seizure and loss of that language skill and verbal auditory agnosia, then LK syndrome should come to our mind. Seizures are of several types, many forms of seizure, and it is bi-amplitude, spike and wave discharge. Most tend to be bitemporal. What we will get in easy bitemporal association, high amplitude, spike and wave discharge. Each features most apparent during non-REM sleep. This is one MCQ. In which stage we will get ease abnormality? This is in the phase of non-REM sleep. So ease should be done during sleep. That is the characteristic in LK syndrome. Ease should be done in non-REM sleep. Treatment of aphasia is diazepam, your night diazepam, and oral prednisolone. There are certain conditions, certain seizure disorders, syndromes where prednisolone is indicated. One is LK syndrome, another is your infantile spasm. Next, which AED can cause blindness? Answer is vigabatrin. Vigabatrin is the molecule that can cause irreversible visual loss. Then, to know something about other AEDs, phenytoin, what are the side effects? Most commonly, gingival hyperplasia, hirsutism, hypocalcemia, megaloblastic anemia, all these, even vertigo, ataxia, nystagmus, we can get in phenytoin. And one thing, we have to advise phenytoin to be given slowly, because rapid IV push can cause ventricular arrhythmia, and that can cause death. That is important, that we have to know in relation to phenytoin. Second, sodium valproic acid that can cause hepatic necrosis, that can cause weight gain. Then carbamazepine, typical side effects are hyponatremia and agranulocytosis. Another MCQ, topiramate and zonisamide. These are the ADs which can cause renal calculi. There are many adverse effects, but these are the important adverse effects related to our ADs which we should remember. Next, subcortical calcification seen in which torch infection? This is one important question. The answer is congenital Zika virus. We know about your congenital toxo, CMV, all these, but congenital Zika virus infection can cause subcortical calcification. Congenital toxo can cause diffuse cerebral calcification, as it is seen the first slide. Diffuse cerebral calcification, this is associated with your congenital toxo. Periventricular calcification, second picture we are getting periventricular calcification, that is associated with congenital CMV. Next, your subcortical. Third is your congenital HIV, that can cause basal ganglia calcification. The fourth one, last one, and this one here we can get subcortical calcification, that is classical to your congenital Zika virus infection. So you have to remember, the question may be asked, congenital toxo can cause diffuse cerebral calcification, congenital CMV, periventricular calcification, congenital HIV can cause basal ganglia calcification, and subcortical calcification we can get in congenital Zika virus infection. Next, earliest response to iron in iron deficiency anemia is, this is most confusing because we used to write it is the increase in reticulocyte, but it is not. The answer is replacement of intracellular iron enzymes is the earliest response to your iron therapy, that can occur 12 to 24 hours after iron replacement. So iron replacement, that within 12 to 24 hours we can get replacement of the intracellular iron enzymes like catalase, all this, and subject to improvement will be there. Then what will occur afterwards? Within 36 to 48 hours you can get erythroid hyperplasia. Between 48 to 72 hours we can get reticulocytosis. So reticulocytosis, what we are usually answering, that can be seen after 40 to 72 hours. Why it is reticulocytosis? Because in the option itself, reticulocytosis would be the earliest response might be. So, but the earliest response is replacement of intracellular iron enzymes. That we have to remember. We should not get confused in exam. Then day 4 to day 30, what we will get? Increase in hemoglobin level. Then 1 to 3 months after iron supplementation, we will get repletion of the iron stores. Next, DPT vaccine can be given as catch-up vaccines up to what age? Up to what age we can give DPT vaccination? Answer is 7 years. Something about it, because always they used to ask one question related to your vaccination. So we have to know up to what age the DPT, capital DPT can be given. It is up to 7 years, completion of 7 years. Up to 7 completed years, we are allowed to give DPT. Then after that, what to be given? After that, we can give Tdap. Tdap can give in after 7 years. If somebody has missed the opportunity of taking the vaccine before 7 years, then we cannot give DPT. We have to give Tdap. Then to our PCV, your pneumococcal conjugative vaccine can be given up to 5 years. It is indicated up to 5 years as per IP, except certain situations like your sickle cell, nephrotic syndrome, immunocompromised stress. There we can give afterwards, but up to 5 years it is recommended. Similarly, BCG, your HIV, your OPV, and IPV are indicated as catch-up vaccination up to 5 years. Up to 5 years, we are allowed to give. One thing, BCG, as per NIS, it is recommended up to 1 year, not up to 5 years. As per IEP, it can be given up to 5 years, but as per NIS, it can be given up to 1 year. Similarly, rota schedule, that schedule has to be finished before 8 completed months as per IEP. But as per NIS, the schedule has to be completed before 1 year. So relaxation is there in NIS up to 1 year, but in IEP, before completion of your 8 completed months, we have to complete the rota schedule. Next, identify the ECG. What you are getting in this ECG? This is a typical ECG. What you are getting? This circle mark we are getting the delta waves, the QRS prolongation and short PR. This is the classical, no second thought about this. This is WPW syndrome. WPW, what we are getting W for wave we are getting delta wave, P, PR interval, short PR interval, less than 0.12 second, you are getting in WPW syndrome. Why? Again, W, wide QRS complex. So WP syndrome, easy to remember, delta wave, short PR interval and wide QRS complex. This ECG you can get in exam. This ECG picture will be there. And identify the ECG. What is the diagnosis? And answer is WPW syndrome. Then to recap what we have discussed today. Holliday Segar formula is used to calculate both calorie and fluid. Fluid as per the present weight, but calorie as per the expected weight. That is important. Pregnant dialer and free fatty acid are responsible for breast milk jaundice. Features suggestive of pancytopenia in a child with absent radius and thumb. Think of Fanconi anemia. Austin flint murmur found in severe AR. DPT catch-up vaccination can be given up to 7 years. Then sudden onset of aphasia in a seizure disorder, we have to think of LK syndrome. Bigabatin can cause blindness. Zonisamide, topiramate can cause renal stone. Subcortical calcification is seen in congenital Zika virus infection. WPW syndrome, what are the classical findings? Short PR, delta waves and wide QRS complex. This we have to remember. Please like and share this video and subscribe to my channel. Thank you.